Picture this. You are sitting on that paper-covered exam table. The nurse wraps the cuff around your arm, pumps it tight, watches the numbers, and writes something down without a word. The doctor walks in, glances at the chart, and before you have finished your second sentence, the prescription pad is out. 140/90. Here, take this once a day. Come back in 3 months. The whole exchange takes 90 seconds. Nobody explains what the drug actually does inside your chest. Nobody tells you how it changes the way your heart muscle contracts. Nobody mentions what it does to your energy, your breathing, your ability to climb a flight of stairs without stopping halfway. You take the pill home. You swallow it every morning with your coffee. And slowly, so slowly you almost do not notice, something shifts. You are more tired than you used to be. Your hands are cold. Walking to the mailbox feels heavier than it should. You mention it at the next visit and hear 5 words that shut the conversation down. That is just your age. Right now, tens of millions of Americans over 50 are taking a class of blood pressure medication and have never once been told what it is doing to their heart. Not what it does to the number on the cuff, what it does to the organ itself. This is not about scaring you off your pills. Nobody is telling you to flush anything down the toilet. This is about understanding what you are swallowing every single morning and why your body has been whispering that something is not right. Before we talk about the pill, we need to understand what blood pressure actually is. Not the number on the screen, the physical event happening inside your body right now as you sit here. Your heart is a pump. It squeezes roughly 60 to 80 times per minute, and with every squeeze, it pushes blood out into your arteries. Those arteries are not rigid pipes. They are elastic tubes that expand with each pulse and then spring back. Blood pressure is simply the force that blood exerts against the walls of those tubes. The top number, systolic, is the pressure during the squeeze. The bottom number, diastolic, is the pressure during the pause between beats. Here is what most people get wrong. They treat a single blood pressure reading like a final verdict. One high number at the doctor's office, and suddenly you are a hypertension patient. But blood pressure is not a fixed number. It fluctuates all day long. It rises when you stand up from a chair, when you argue with someone on the phone, when you drink your second cup of coffee, when you rush to make an appointment on time. A reading taken in a stressful medical office with a cuff that may not even be the right size for your arm, while you are anxious about what the doctor might say. That number can be 10 to 20 points higher than your actual resting pressure. Doctors have a term for this: white coat hypertension. It is real, it is common, and people get medicated for it every single day. The other thing nobody explains clearly enough is that the target number, the threshold where doctors decide you need medication, has been a moving target for decades. What was considered acceptable at 65 20 years ago is now flagged for treatment, and what counts as dangerously high for a 35-year-old is a completely different conversation than what matters for a 68-year-old with stiff arteries and reduced cardiac reserve. That distinction matters enormously for what happens next. Now let me be fair. Chronically elevated blood pressure is genuinely dangerous. Your doctor is not wrong to take it seriously. The concern is real. Here is what happens when pressure stays high for years. Think of your arteries as tubes lined with a microscopically thin, perfectly smooth inner coating. That coating is called the endothelium. When blood flows through at normal pressure, everything glides, nothing sticks, nothing tears. But when pressure is elevated day after day, month after month, that smooth lining takes a beating. It is like running sandpaper along the inside of a hose. The endothelium develops micro-injuries, tiny areas of damage you cannot feel, and no scan will catch early. Those damaged spots become sticky, cholesterol particles start clinging to them, platelets pile on, inflammatory proteins arrive and make things worse. Over time, those deposits harden into plaques. The artery walls thicken and stiffen. The opening narrows. The vessel that once expanded and contracted with every heartbeat becomes a rigid, narrowing tube. That is the road to a heart attack. That is the road to a stroke. That is how kidneys quietly fail over a decade. That is how blood flow to the brain drops just enough to fog your thinking and erode your memory year by year, a process called vascular dementia. So let me be absolutely clear. This video is not anti-medicine. Treating high blood pressure saves lives. The science on that is settled. The problem is not that doctors treat blood pressure. The problem is how they treat it, with which drugs, at which doses, and what they stop paying attention to once the prescription has been written and the number on the cuff looks acceptable. The drug class one want to talk about is called beta blockers: metoprolol, atenolol, propranolol, Carvedilol. If you are over 50 and take blood pressure medication, there is a very good chance one of these names is on your bottle right now. Beta blockers are among the most commonly prescribed cardiovascular drugs on the planet, and most people taking them have never had the mechanism explained in plain language. So here it is. Your heart has receptors on its surface that respond to adrenaline. When adrenaline lands on those receptors, your heart beats faster and contracts harder. That is the system that lets you run from danger, climb stairs, react to stress. Beta blockers sit on those receptors and block adrenaline from reaching them. The result is a heart that beats slower and squeezes with less force. Blood pressure drops, the number on the cuff improves. On paper, problem solved. But here is what the prescription label does not say. You have just told your heart to beat weaker, not just slower, weaker. For a healthy 40-year-old with anxiety-driven high readings, that trade-off might be perfectly reasonable. But for a 62-year-old whose heart muscle is already losing contractile strength with age, whose circulation is already less efficient, whose ability to exercise is already declining naturally, you are now stacking a pharmaceutical break on top of a biological one. The medical term for what follows is reduced cardiac output. Your heart is simply pumping less blood per minute than your body needs. What does that feel like from the inside? Chronic fatigue that sleep does not fix. Breathlessness climbing stairs you used to take 2 at a time. Cold hands and feet, even indoors. Brain fog. Weight gain that will not budge no matter what you eat. Depression that appeared out of nowhere. You report every one of these to your doctor, and you hear the same 5 words. That is just your age. It is not just your age. This is the part most viewers will never hear from their physician. There is a concept in cardiovascular research called the J-curve. It describes something that sounds counterintuitive until you think about it for 30 seconds. Lowering blood pressure reduces risk. That is true, but only to a point. Push the number below that point, and the risk does not keep dropping. It climbs back up. Picture a 70-year-old whose arteries have been narrowing for decades. Those vessels are stiffer and tighter than they were at 40. To push blood through that narrower system, the heart needs a certain minimum pressure. Take that pressure away with aggressive medication, and the blood simply does not arrive where it needs to go. The brain gets less oxygen. You feel dizzy when you stand up. Your thinking gets foggy. Your kidneys, which depend on adequate blood pressure to filter properly, start underperforming. And then comes the consequence that changes everything. You stand up from a chair too quickly. The world tilts. You reach for the counter and miss. A fall after 65 is not a bruise and a funny story. It is a fractured hip, surgery, weeks of immobilization, blood clots, pneumonia, and a recovery that some people simply never complete. Here is the part that should concern you. In recent years, guideline committees have pushed the target blood pressure numbers for older adults lower and lower. Many physicians are now medicating patients into ranges that a growing body of research suggests are too aggressive for their age group. The number on the cuff went down. The doctor is satisfied, but the patient feels worse, more tired, more dizzy, less steady on their feet. Those two facts are directly connected, and almost nobody is making that connection for you. You just heard something that most people on blood pressure medication have never been told, that the target number your doctor has been chasing may not be the right number for your body. Most people hear this information, feel concerned, and do nothing. They go back to their routine and hope it works out. But you can actually take a step right now. Care Health is a free platform that connects you with cardiac screenings, blood pressure monitoring programs, and clinical trials for heart disease in your area. You fill in a short form, your date of birth, gender, whether you have kids under 18, and Care Health matches you with relevant options near you. Takes 30 seconds, no cost, no commitment. If you have been on the same blood pressure medication for years and nobody has reevaluated whether your current dose or drug class still makes sense for where your body is today, this is how you start that conversation. Click the link in the description or scan the QR code on screen. Just point your phone camera at it and tap the link that appears. Now back to what you need to know about what these drugs are doing inside your body. I want to walk you through something that happens in my practice constantly. A patient comes in and lists their complaints. Constant fatigue, the kind where a morning walk to the end of the street feels like a hike. Weight gain that showed up a few months after starting a new medication and refuses to move no matter what they eat. Hands and feet that stay cold even in a warm house. Sleep that feels broken, interrupted by strangely vivid or disturbing dreams. A low mood that settled in gradually, not sadness exactly, more like the color drained out of daily life. And in many cases, sexual dysfunction that the patient is too embarrassed to mention and the doctor never asks about. Every single one of these has a direct physiological explanation tied to beta blockers. The fatigue and exercise intolerance come from reduced cardiac output. Your heart is pumping less blood per minute, so your muscles get less oxygen during activity. The cold extremities happen because when cardiac output drops, your body prioritizes blood flow to vital organs and pulls it away from the hands and feet first. The weight gain is metabolic. Beta blockers slow your resting metabolism and impair your body's ability to burn fat efficiently during exercise. The depression and emotional flatness occur because certain beta blockers cross the blood-brain barrier and dampen the same adrenaline signaling that drives motivation, alertness, and emotional range. The nightmares are a known neurological effect of that same brain penetration. These are not rare side effects buried in the fine print that affect 1 in 10,000 patients. These are predictable, dose-dependent consequences of how the drug works. If you block adrenaline receptors on the heart beats weaker. Everything downstream from that follows logically. Your body has been telling you. The question is whether anyone has been listening. I need to stop here and say something directly. If you have been listening to the last 3 chapters and a voice in your head is saying, "That is it, I am done, I am throwing these pills in the trash tonight," do not do that. I mean it. Stopping a beta blocker abruptly is one of the most dangerous things you can do to your heart. Here is why. Your body is not passive. It adapts to every drug you take. When a beta blocker sits on your adrenaline receptors and blocks them day after day, your body notices that adrenaline is not getting through, so it responds the way any intelligent system would. It builds more receptors. It grows additional landing pads for adrenaline on the surface of your heart cells, essentially trying to compensate for the ones that are being blocked. While you are taking the medication, that does not matter. The drug is still sitting on the old receptors and the new ones are covered too. The system stays suppressed. But the moment you stop the drug cold, every single one of those receptors, the original ones and all the extras your body built, is suddenly wide open, unblocked, and adrenaline, which has been waiting in the wings, floods in all at once. Heart rate spikes, blood pressure surges. The heart, which has been running in low gear for months or years, is suddenly slammed into overdrive. Doctors call this rebound hypertension. It can trigger a heart attack. It can cause a stroke. It can throw your heart into a dangerous irregular rhythm. This is not a theoretical risk. This happens in emergency rooms regularly. So let me be clear about the message of this video. It is not stop your medication. It is understand your medication well enough to have a real conversation with your doctor about whether the drug, the dose, and the plan still make sense. Any changes happen gradually, under supervision, with monitoring. Never on your own. Here is what typically happens after you get that first prescription. You take the pill. You come back in 3 months. The nurse checks your blood pressure. The number looks good. The doctor renews the prescription. See you in 3 months. That cycle repeats for years, sometimes decades. And in most cases, that is the entire extent of the follow-up. The number is down, so the job is done. But the number is not the whole story. It never was. A thorough medication review should include several things that most patients have never been offered. First, heart rate trends. If your resting heart rate is consistently sitting below 55, and especially if it is dropping into the upper 40s, your beta blocker dose may be too aggressive. A heart beating that slowly may not be pumping enough blood to meet your body's basic needs. That is not a healthy resting heart rate. That is a suppressed one. Second, orthostatic blood pressure. That means measuring your blood pressure while you are lying down, and then measuring it again immediately after you stand. If the top number drops by more than 20 points when you stand up, your body is struggling to adjust circulation when you change position. That is a direct fall risk, and as we discussed, one fall after 65 can change the entire course of a life. Third, kidney function. Your kidneys filter your blood under pressure. Change that pressure with medication, and you change how well they work. A simple blood test measuring creatinine and glomerular filtration rate tells you whether your kidneys are handling the drug well or quietly declining. This should be checked regularly. It often is not. Fourth, an echocardiogram. This is an ultrasound of your heart. It shows how strongly your heart is actually contracting and how much blood it is pumping out with each beat, a measurement called ejection fraction. If you have been on a beta blocker for years and nobody has checked whether your heart's pumping power is holding steady or gradually dropping, that is a gap in your care. Fifth, electrolyte panels. Some blood pressure medications deplete potassium and magnesium over time. Both of those minerals are essential for normal heart rhythm. Low potassium or magnesium can cause palpitations, cramping, and in serious cases, dangerous arrhythmias. Write these 5 things down: heart rate trends, orthostatic blood pressure, kidney function, echocardiogram, and electrolytes. Bring that list to your next appointment and ask whether any of them have been checked recently. You have a right to know. The answer is yes, but not in the way you might hope. There is no magic replacement pill that fixes everything with zero trade-offs. Medicine does not work that way. What does exist are other classes of blood pressure medication that lower the number through completely different mechanisms, ones that do not directly tell your heart to beat weaker. ACE inhibitors work by blocking a hormone that tightens your blood vessels. The vessels relax, pressure drops, but your heart's contractile force stays untouched. ARBs do something similar through a slightly different pathway. Certain calcium channel blockers relax the vessel walls by affecting how calcium enters the smooth muscle cells that wrap around your arteries. Again, pressure goes down without suppressing the heart's ability to pump. Whether any of these would be a better fit for your specific situation is a conversation between you and your doctor, not a decision you make from a video. But knowing they exist matters, because many patients have no idea there were other options on the table. Now, beyond medication, something that surprises most people: lifestyle changes. The things that sound too simple to work actually produce measurable, significant drops in blood pressure. Reducing sodium intake, walking consistently, managing weight, improving sleep quality, and lowering chronic stress can each reduce blood pressure by several points. Combined, studies show reductions of 10 to 15 points, sometimes more. For some patients, that is enough to lower the dose. For others, under medical supervision, it is enough to come off medication entirely. Magnesium and potassium-rich diets show real effects on arterial flexibility and vascular tone, not supplement industry hype. Published data. The point is not that drugs are bad. The right medication at the right dose for the right patient is excellent medicine. The wrong medication at the wrong dose for a patient who was never reevaluated is something else entirely. This is where most people lose the game before it starts. You walk into your appointment, you have 12 minutes. The doctor is already behind schedule. You sit down and say something like, "I do not know. I just feel tired all the time." Or, "I just do not feel right." And the doctor, who hears vague complaints dozens of times a day, nods, glances at your blood pressure, sees the number is acceptable, and moves on. Prescription renewed. See you in 3 months. The problem is not that your doctor does not care. The problem is that vague symptoms get vague responses. Specific questions get specific answers. So here is exactly what to say. Write these down if you need to. I want to review whether my current beta blocker dose is still appropriate for my age and current cardiac function. That sentence alone changes the dynamic of the appointment. You are no longer reporting a feeling. You are requesting a clinical evaluation. I would like an orthostatic blood pressure check, lying down and then standing. That takes 2 minutes and tells both of you whether your medication is creating a fall risk. Can we discuss whether a different class of medication might give me the same blood pressure control with fewer side effects? That opens a door most doctors will walk through if you hold it open for them. I would like to know my current ejection fraction. Has it been checked since I started this medication? That is a question most patients have never asked in their lives, and it is one of the most important numbers you can know about your own heart. This is not about confrontation. You are not firing your doctor. You are not walking in with a printout from the internet and demanding they change everything. You are upgrading the conversation from passenger to participant. Doctors trained for years to answer exactly these kinds of questions. Most of them are just waiting for someone to finally ask. Everything we have covered means nothing if you do not act on it. So here is your plan, starting tonight. First, start a blood pressure journal. Get a notebook, a scrap of paper, anything you will actually use. Measure your blood pressure at the same time every morning and every evening for 2 weeks straight. Sit down, feet flat on the floor, arm resting at heart level, and stay still for a minute before you take the reading. Write down both numbers and your heart rate. Do it at the same times each day. That 2-week record is worth more to your doctor than any single reading taken in a rushed office visit with a cuff that may not even fit your arm properly. It shows patterns, it shows trends, it shows what your blood pressure actually does in your real life, not in a fluorescent lit exam room where your stress level is already elevated. Second, on that same page, next to each reading, note how you feel. Rate your fatigue on a simple scale. Write down whether you felt dizzy when you stood up. Note how you slept the night before. Track your mood. You are not being dramatic. You are building a case file, not for a lawsuit, for a better treatment decision. When you hand your doctor a page full of specific dated observations instead of a vague, "I just feel off," the conversation changes completely. Third, go find your medication bottle right now. Read the label. Know the name of the drug, not just the color of the pill. Know the dose in milligrams. Think about how long you have been taking it. If the answer is more than 2 years at the same dose and nobody has reevaluated whether that drug at that strength still makes sense for your body today, that is worth bringing up at your next visit. Fourth, and I want to repeat this because it matters, do not stop anything on your own. Do not cut your dose in half because this video made you nervous. Do not skip a day to see what happens. Everything I have said today is meant to prepare you for a better conversation with your physician. It is not a replacement for one. Let me bring this together. Blood pressure medication can save your life. That is not in question. But it can only protect you if it is the right drug at the right dose, monitored properly, and reevaluated as your body changes with age. A pill that made sense 5 years ago may not make sense today. A target number that looked right on paper may be pushing your pressure too low for a heart and a vascular system that are not the same as they were when the prescription was first written. Your blood pressure number going down does not automatically mean your heart is doing better. Those are two different questions, and you deserve answers to both of them. You deserve to know what your medication is actually doing inside your body. You deserve a doctor who will check more than the number on the cuff and ask more than "see you in 3 months." And you now have the language, the checklist, and the understanding to make that happen. Nobody is going to hand you this information at a 12-minute office visit. There is no billing code for sitting down and explaining the J-curve to a patient. That is exactly why this video exists. Everything we covered today is for your understanding and education. Your situation is specific to you, and using what you learned here as a starting point for a real conversation with your doctor will always be more valuable than trying to manage things alone. And remember, that free cardiac screening link is in the description. 30 seconds could change how you manage your heart health from this point forward. Take care of yourself.